We have another panel discussion on hypopharyngeal carcinoma, the moderator of which is Dr. Kinjal Jani, Director and Head of Radiation Oncology Department at HCG Cancer Center, Ahmedabad. The panelists for this session are Dr. Chintan Shah, Medical Oncologist at HOC Vedanta, Ahmedabad. Dr. Deepak Patel, Director and Consultant Radiologist at Infocus Diagnostics. Dr. Malhar Patel, Radiation Oncologist at SIMS Hospital. Dr. Maulik Bezdadia, Radiation Oncologist at SIMS Hospital, Ahmedabad. Dr. Nitin Sharma, Consultant Head and Neck Oncology at HCG Cancer Center. Dr. Bhavin Vadodaria, Consultant Head and Neck Oncology Surgeon at HCG Cancer Center, Ahmedabad. Dr. Raj Jyoti Das, currently a professor at Dr. B. Barua Cancer Institute, Guwahati. Dr. Ravi Deo, currently runs Head and Neck Cancer Clinic at Dr. B.G. Rudrappa Hospital. Dr. Sarvani Ghosh. She's left? Okay. And Dr. Shweta Tilara, Consultant Medical Oncologist at Synergy Super Speciality Hospital, Rajkot.
Good evening all. Dr. Sharbani had to leave because her flight was there. So she's missing in the panel. I think rest of all are there. Yeah. So the panel initially was for 50 minutes, but I'll try to wrap it up in 30 minutes only. I'll try to keep it interactive. As you know, we have heard so many lectures from all the dignitaries that they have shown a lot of evidence and everything. But I'll not talk about any evidence. I'll just talk about the practicality, like how do we approach each and individual case. So I'll be asking the panelists to talk about how would they treat a particular patient when that patient comes to them. Okay, so we'll directly go to the cases. I have 3 cases. If the time is there, I'll talk about the 3rd case. Otherwise, we'll talk about the 1st and 2nd case. So this is a 36-year-old male, has a history of smoking since 15 years, a complaint of hoarseness of voice and difficulty in swallowing since 2 months. So this patient has walked into a cabin of a radiation oncologist. So I'll go to Maulik. I being a radiation oncologist, I'm not being biased, but if this kind of patient comes to a radiation oncologist, what would you do? Maulik?
I will do Hopkins examination and neck examination in the clinical examination and find out the findings.
Okay, so you will not refer to a head and neck surgeon?
Then onwards for the biopsy, or if we find the...
So you can give the mic to the surgeon next to you. Yeah, sir, what would you do?
It's all depend upon the Hopkins finding, because if we find that there is a lesion involving hypopharynx and all, so we like to put an endoscope more down into the esophagus also to see whether there is involvement of post-cricoid region or there is involvement of the upper esophagus or not. And accordingly, we'll go for the imaging subsequently.
Yeah, so this was the Hopkins done. As larynx and hypopharynx are so nearby, this is a lesion in the A fold pyriform and going a bit down also. So this was, I'll replay it once so all of you can have a look. So this was the lesion. As you can see, I think you can describe also. Any of the surgeon can describe the findings.
It looks like the hemilarynx is fixed on the opposite side. Is it?
Okay. Yes, sir.
Just for the youngsters and the students, laryngopharynx have 2 components and therefore they have separate set of symptoms also. Per primum, this case, before he opens the mouth, he's telling me that he has difficulty in swallowing, which indicates he has pharyngeal component as well as difficulty in voice. That means he has laryngeal component, and these 2 things can only happen if he has a paraglottic involvement from a pyriform cancer.
Absolutely.
And therefore, this is not a light case, plus he is very young, and therefore he must have started his habit very young, and I would go from 1, 2, 3, 4 like that. I think whatever I am going to tell you now may be irrelevant. We need to understand that phylogenetically the life started in water, and mammals were breathing in water and drinking and eating. Larynx was incorporated by God Almighty to ensure aspiration-free deglutition. Larynx was not put there as a performing speaking organ. So it is very important that we understand that the primary function of larynx is to ensure aspiration-free deglutition. And in this case, this man has compromised both larynx
Absolutely.
as well as pharynx.
Absolutely,
And
sir. Absolutely.
whatever you have done is enough.
Yeah.
We will just do a direct laryngoscopy and
Yeah,
see.
so, yeah,
but
so-
we need to understand that cancer of the larynx caused by smoking and cancer of the laryngopharynx or hypopharynx are not the same ball game. We may be discussing in one conference, but they are two separate diseases.
Yeah, so rightly said by sir that it's very nicely summarized the findings that it is a disease of hypopharynx as well as the supraglottis. So Bhavin, would you like to do what would you do next? You have this Hopkins findings which you have seen.
Yeah.
How would you proceed further?
I would like to advise a cross-sectional imaging in form of MR neck contrast.
Okay, so let us go to Dr. Deepak. There was a CT scan. This patient came to us with a CT scan. Can you elaborate the CT scan? I have 3 cuts for you.
Yeah, there is a large soft tissue lesion involving a right-sided pyriform sinus with extension into the right paraglottic fat plane, as well as there is a mild extension of the disease is seen between the thyrocricoid ligament, thyrocricoid joint. So it is there is involvement of the larynx as the right-sided supraglottis that false chord, as well as I think partly visualized true chord is displaced medially. So that is also consistent with the clinical findings of this laryngeal fixation. So it falls into the T4A category.
Yeah, that was specifically the reason of putting the last cut. That was specifically for you to comment on the vocal cord. So you rightly mentioned that the cord is medially placed, so that means that the larynx function is compromised. Okay. So again, a question to you, or maybe a surgeon like Mithun, you can take it. Would you advise for an MRI? Just what Bhavin said. Would you go for an MRI or a PET scan? What would you do? So this is the CT scan you are having. You will decide your treatment on this.
Any day, if you want to assess the soft tissue, MRI is better than CT scan.
Okay. How about the PET scan?
Yeah, it depends upon availability.
So it's a no. It's not about availability. It's a clinically T4N0 lesion.
So MRI is okay.
MRI is okay.
But along with metastatic workup, so we
Yeah.
need to take the cuts of or CT of thorax as well.
Sir,
One advantage of doing MRI is there, CT scan is showing there is an involvement of postcricoid region.
Yeah.
So there may be a submucosal extension beyond that also. So that will be more easily picked up by MRI rather than a CT scan.
Absolutely. So rightly mentioned by all the surgeons that we would do an MRI for this patient. One, to know the exact soft tissue extension going into the postcricoid and the involvement of cartilage also. And if you're not doing a PET CT, as it's a N0, you can do a metastatic workup in the form of CT thorax and upper abdomen. So now, we have done everything. We have got a PET CT done. Now this patient is clinically T4A, N0, M0. The erosion of the cartilage is subtle. It's not fully involved. So I'll start with the surgeons first. What would you do? It's a T4A, N0. The surgeon, any of the surgeons can take it. Sir.
That surgery is going to be done, there's no doubt about it, but
Okay.
we need to assess the involvement of the pharynx. As a rule, if you have dysphagia or rhinophagia, particularly in hypopharynx, that means probably 75% of the lumen is compromised circumferentially. And in hypopharynx, if you are going to take a negative margin properly, this man would need reconstruction also. That is my issue. Issue is not laryngectomy. A person who is taking up this case should be well versed that this man will end up with a patch plasty or something like that. And I will first do a proper DL-scopy evaluation to assess the pharyngeal mucosa, how much is left there. And if it is showing extension to the esophageal inlet, then that becomes a really different story, because then he will end up with circular laryngopharyngectomy. So these are the issues which we need to understand. Just by his symptoms, before you do anything, by his symptoms of odonophagia or dysphagia, it tells us very clearly, loudly, that these are kind of. After that, we do a standard laryngectomy, neck dissection, and followed by whatever.
So yeah, so this patient came to MDT. So now there was a discussion in the MDT. Dr. Chintan was there in the MDT. Chintan, what would you advise for this patient? This is a 36-year-old male having a T4A subtle erosion of the arytenoids N0, M0. Chintan.
Yeah, so I think the larynx is compromised. That's what we discussed.
Yeah, so patient is not aspirating. It's a partially fixed. You can say the mobility of the vocal cord on the right side was partially mobile. You know, it's not completely fixed, but it was partially mobile. Yeah.
Yeah.
So it's a T4A N0.
Yeah, but if as per what we discussed in T4A N0, if upfront surgery is feasible, I would be more okay with the surgical aspect. Yeah.
Any difference, Nitin or Bhavin? Sir wants to make a comment? Yes, sir.
Yeah, so why this is T4? It's because of the exolaryngeal spread on the lateral side.
It is involving the cartilage.
Yeah, so it's not thyroid cartilage which is
No,
involved.
not thyroid cartilage. It's the arytenoids involved.
Yeah, so involvement of arytenoid, we really don't know. So, I mean, the literature says thyroid cartilage always. Arytenoid, I would like to see the scans if it is just subtle erosion or minimal kind of an problem. I would still like to give a neoadjuvant chemotherapy to this patient. If the larynx is functional and you say that it is functional.
Functional larynx.
Would like
36-year-old guy.
I would explain him that most probably you'll undergo surgery. This is one try which we can do with a neoadjuvant chemotherapy. If you respond very well, then there is a possibility of chemoradiation and organ preservation.
Yeah, well summarized, yeah.
Larynx is functional from point of view of
Not aspirating.
Not aspirating,
Not aspirating.
but
Not
voice
aspirating.
is already compromised,
Voice is
which
compromised.
indicates that there is a paraglottic spread from posterior to anterior.
Yeah.
That means the paraglottis is involved in the area which is the most dangerous.
Yeah.
That is the difference between a laryngeal paraglottic spread which comes from medial to lateral and pharyngeal which comes from posterior to anterior. And this is not a good paraglottic spread. So though larynx may not be aspirating, he is compromised.
Okay. Any comments? Anybody? Yeah, Nitin, yes.
So, age of the patient is 36 years, right?
Yeah.
So, young patient, so knocking down a larynx in 36-year-old patient with subtle erosion. So, I feel we should at least try for NACT.
Okay.
Evaluation of with MRI. Yeah. And then if there is subtle erosion, then we can try NACT first.
Shweta, would you agree? NACT, trial of NACT?
Yes, sir.
Malhar, you wanted to make a comment?
Why not upfront radical radiation with concurrent chemotherapy?
I've given you the option.
Yes, definitely. I'll go.
You are the experts.
The function is good. There is no aspiration. No doubt the voice is compromised, but definitely looking at the lesion, the voice will be compromised. But the primary function, as sir rightly mentioned, is the prevention of the aspiration. Larynx is functional. We can definitely go for the radical radiation with concurrent chemotherapy.
Okay. So that is an option. Point taken, but the point is, where there is
the only problem with that is that if this patient doesn't respond to chemoradiation, the surgery will be very difficult. So with complications. So if you can predict the biology of the disease by neoadjuvant chemotherapy, there you will be able to go aggressively with chemoradiation, otherwise you go for surgery.
I tend to agree with Kaustav that we should think that operating after chemo RT is going to be difficult, and in case it is going to recur, we should have option of good healing, and probably upfront chemotherapy may tell you about the biology, but I don't know about the audience and the papers. But in India, cancers occurring in younger people do have aggressive disease.
Aggressive disease, absolutely.
And there is no doubt in our mind, irrespective of the site, they have aggressive
Absolutely.
disease.
So I absolutely take your point that any young patient with any malignancy of the body, they are very aggressive tumors. So I would be tempted to go for a surgery for such a lesion because it's an aggressive lesion. But yes, we can give a trial. So this patient was given 3 cycles of TPF. What Dr. Kaustubh had said, that give a trial of TPF. If the patient responds, you know that the biology is responding, you can go for a radical chemo.
But what is your protocol of giving these 3 trials? Because there has to be a method.
So it is-
You give first chemo, see the percentage of shrinking.
Absolutely.
If it is more than
Every-
50,
yeah,
again.
yeah,
So,
yeah, yeah.
so there has to be a
every
method.
before every cycle, the protocol at our place is after every cycle the patient is re-evaluated, and the responding patients are only continuing the second or the third cycle. So that is very important. But this is just the patient was given 3 cycles of TPF. The larynx is fully mobile, like the vocal cords are fully mobile. Responded well. The residual lesion was quite small, and I'll just start again. Yeah, so it is like 1.5 by 1.5 by 1 centimeter tumor in the right piriform, going a bit to A folds, no nodes again. So now again, we are back to the next question. What next? Do we go for RT alone? We go for RT plus CT? We go for radiotherapy plus targeted therapy plus chemotherapy. Maulik, what would you do? Because this patient would come to a radiation oncology department. Maulik.
Go for RTCT.
Okay. Malhar? Okay, what about only radiotherapy? Anybody about only radiotherapy? Anybody giving only radiotherapy? Anybody in the audience giving only radiotherapy?
As we have already discussed, being a young patient with an aggressive nature of the disease, better we should consider for RTCT.
Absolutely. So we routinely do chemoradiotherapy for this patient.
Kinjal.
Yeah, sir, I'll take your comment. This was specifically I had put it here to ask you or Toprani sir about this comment. But the point is, in NCCN for hypopharynx, it is mentioned even for a N3 disease, N3 disease, patient has responded to neoadjuvant chemotherapy. If there is a complete response to the primary site, even if there is a less than partial response to node, you can go for only radiotherapy. That is the category 1. Category 2 is chemoradiation after neoadjuvant chemotherapy. So I think sir can comment what he...
I think I like Anil to comment. Yeah, so, there is no level 1 evidence that after neoadjuvant chemotherapy, if the patient has responded well, you should add chemotherapy to radiation. There is no level 1 evidence. There is no trial in the world which has established this till today. So the case can come to tumor board, you can discuss the pros and cons, but somebody who is doing only radiation is all right for these kind of patients.
Yeah. So you all rightly mentioned that we go for chemoradiation. I also would go for chemoradiation, and Dr. Kaustubh would agree for this patient. We would go for chemoradiation. Just wanted to make a comment, like what sir mentioned. They just been to UK for a meeting, and they had a long discussion on this. Again, a question to Shweta or Chintan: would you be tempted to add a targeted drug like cetuximab or nimetuzumab in this patient? Young patient had a very advanced disease. Now it's like a T1, but it was a T4 to begin with.
Yeah, so actually this data is all after neoadjuvant therapy. So again, whatever trials and data we have, it's more about the upfront setting where definitive CT-RT was given and nimetuzumab, biomab was added. And there were a lot of patients who had T3, T4 and even hypopharyngeal patients are involved in that trial. And those patients did well, both in terms of disease-free survival, and there was a retrospective analysis for HPV negative patients where we all saw that it was an OS benefit as well. But if I remember, there were hardly very few patients who have received neoadjuvant therapy and then taken in that trial. So here I would be skeptical of adding nimetuzumab.
Okay, so the NCCN mentions that after giving the systemic chemotherapy upfront, and when you like neoadjuvant chemotherapy, and when you go for a concurrent chemoradiation afterwards, you can give carboplatin along with radiotherapy, or you can give cetuximab in a selected group of patients. So the selected group can be a patient who is like elderly patient who's
Cisplatin ineligible.
Absolutely. So those are the patients where you might think of adding cetuximab or a bulky lesion still remaining after radiotherapy, after chemotherapy. But like for a patient like this, we would definitely go for a chemoradiation. So this patient underwent a chemoradiation afterwards. So we'll not go further because it's only 12 minutes remaining. I'll go to the second case. So it's a 55 male chronic smoker again, came with the right neck swelling since 2 months, gradually increasing. No other complaints, no deglutition problem, nothing. FNSC was done somewhere outside. It was showing metastatic squamous cell carcinoma. Clinically, it was a 5 by 5 centimeter hard, partially fixed mass in the right level 2, level 3. So how would you evaluate? Any of the surgeon can take it. Bhavin, you can take it. How would you evaluate this patient?
I will order a whole body PET CT scan.
Before that, patient is coming to you in your clinic.
I will do a oral cavity examination, neck examination, as well as Hopkins examination in my OPD.
Anything else? Though we are discussing hypopharynx, but this is an MUO coming to you. Would you examine anything else?
Yes, triple and in
Absolutely.
nasopharyngeal pan endoscopy.
Yeah, you have to do a pan endoscopy. So this kind of patient comes to you, you do a pan endoscopy and evaluate whether nasopharynx or hypopharynx or oropharynx has a disease or not. Okay. So that is the first thing which you do. I'll just show you the finding of this patient.
Just go back, what level of node is involved?
Level 2 and 3, 5 centimeter hard node. So this was the Hopkins of this patient.
Right PFS.
It was the right sided node. Nitin, you want to comment? Yeah, Nitin, you can comment.
So,
Yeah. Absolutely.
so right
Absolutely.
PFS lesion is there, otherwise
Yes.
mobile vocal cords. and
Absolutely.
Rest of examination is normal.
Yeah, absolutely, absolutely. So there is a small growth, so the video quality is not good, but you can see there is a lesion here in the right pyriform, a slough area. So it looks like a T1 kind of lesion with a N3B node. This is a real scenario case. This was a case seen by Parin only. So this patient had a T1 lesion. Obviously, because being a very large node, we got a PET CT scan done. Before we go to a PET CT, I would just take the CT and ask the opinion of Dr. Deepak. Can you describe this CT scan, Dr. Deepak?
Yeah, visible part of the supraglottis and this hypopharynx don't show any lesion, but I think the lesion must be in the apex of the pyriform sinus, which is situated little below. So I think we cannot see the primary lesion. Where most of the time in MUO we do see a small, very small lesion in the apex of the pyriform sinus, and then you get the infiltrative nodal disease or and this patient has large heterogeneously enhancing nodal mass at the level of 2-3 and which is invading the overlying sternocleidomastoid muscle.
Exactly.
But and medially it slightly displaces the carotid vessels, but it is not encasing the carotid vessels. Rest, I think the rest structures are
Exactly.
predefined.
Yeah,
Predefined,
true.
yeah.
So this is the PET CT. We can see the PET CT. As you rightly mentioned, nothing is seen in the pyriform. A small lesion maybe at the apex. And this was the report of the PET CT, high-grade FDG avid lesion, level 2-3. There were multiple nodes, but it was like a node-matted node, compressing on the IJV and CCA as rightly mentioned by you, and it was adherent to the submandibular gland and involving the sternocleidomastoid. So now this case has come to MDT. There is M0. It's a T1 N3B. It's a clinically extranodal spread is there. So it's a clinically T1 N3B M0. So this case comes to MDT again. So any
is there biopsy from the pyriform sinus?
Yes, it's positive. Both are positive. Pyriform is showing a moderate differential squamous cell carcinoma. Yes. The surgeons, how would you approach? You would.
Per primum, this is a curable primary with a bad, so the limitation factor is the neck. The primary is radio curable. So, and you are telling that the node is not very nice, it is partly fixed and other. We can have two kinds of approaches, I have my own philosophy that I would give an upfront chemo, make the node which will become, free and free. I would do an upfront neck dissection in healthy person and then give radiation therapy as per the radiation therapy wants to the primary. We can do another option that we can give CTRT and then see if the node, but why I am telling we should do upfront, in few cases my hands got burned. After we gave chemo-RT, when we tried to remove that node, it was so stuck with the surrounding structure that we ended up in resecting vagus and hypoglossal, and I lost that patient because of surgery. He didn't die of disease because he had aspiration. So I don't know whether I'm right or wrong, but
that is one of the approaches. I agree.
I feel that just giving CTRT, sometimes the node gets fixed to the surrounding and it becomes very difficult to, so if the node is big, probably we should be careful.
True. Sir wanted to make a comment.
First option will be radical CTRT, because if we give chemo to the chemo in first sense, we do not know the sensitivity of chemosensitivity of the tumor. Okay. So if you give chemotherapy first, if the tumor is not responding, and you have already done a neck dissection, then you are at a loss.
Okay.
So
Maulik
we'll
wanted to make
proceed
a
with
comment?
CTRT.
First R&D,
Okay.
neck dissection followed by CTRT.
So I
So
think,
why not
I
R&D
think, I
first?
think Dikrus sir made a
Why
comment
not
sometime
R&D
back.
first, sir?
Maulik,
Is
Maulik,
it possible?
You can do R&D first. There is no object. What I am trying to do is that neck first.
Maulik. Yeah, so same. So he said the same thing. He said the same thing. Dikrus sir had made a comment like sometime back. You know, he said that we used to do split therapy. Like this would be a case. This actually would be a case where split therapy would be useful because it's a small primary.
No. That used to be in the old days, and I'm repeating, when we didn't have PET scan and we didn't have CTRT. Ravi is saying that he had hypoglossal fixed. What happened if he operated this patient up front and had to remove the vagus? 20% of patients extended resections. You delay definitive therapy. You have to go definitive therapy today. You remove the sternocleidomastoid, you have got a carotid pulsating under your skin flap. No radiation oncologist will take to 7,000 rats with that kind of setup. You have shown sternocleidomastoid.
Absolutely involved. Absolutely involved.
Who will give 7,000? You have to give radical dose because the primary is there.
That was the reason this case was put, because I knew that there is going to be a difference of opinion. So one
Please
person
do
says go for a
not
neck
do the
dissection.
split therapy. That was treatment of 1992. Bob Byers did, then we did after that. Ashok Shenoy did. I think only 3 papers. Now we've got CTRT and PET. Please do CTRT PET.
Anybody going
I
for
agree
NSCT?
with Guwahati plan.
NSCT, anybody going for NSCT?
Sir, this is very bulky disease, bulky node, and these patients are also at high risk of distant metastasis. So this is where somewhere there is role of preferred role of neoadjuvant chemotherapy, and you assess the biology of the disease as well.
So usually we go for an NSCT, as rightly mentioned by you, we usually go for an NSCT where there is a large bulky primary
disease.
or a primary node. So, and I like this case was again discussed at our MDT, and we had a discussion of all the options we had discussed, that, you know, how to approach this patient, because everybody may be right, everybody may be wrong. Like there are some advantages of going for a neck dissection first followed by radical CTRT. There is an advantage of giving neoadjuvant chemotherapy. The only problem with NSCT, because it's a bulky nodal disease, if this patient does not respond, you waste time for these patients. Because traditionally the primary respond better than node. That is what we have seen. So that can be one of the things. Then rightly mentioned by sir that if you go for a radical RTCT, if then you have to operate, then it might be difficult to operate. So, you know, all the options are there. Or you add targeted drug along with chemo radiation to this patient. Kaustubh sir wanted to make a comment.
Yeah, so, you know, time to come. We have seen that neoadjuvant chemotherapy doesn't act well on the nodes. That has been experience of all of us. Now comes immunotherapy. Neoadjuvant immunotherapy works well on the lymph nodes. So that maybe in future we'll have some papers which will evaluate nodal disease. We don't know.
There is data of, even data of chemo along with Erbitux.
Yeah.
There are phase 2 data where they have given excellent response rates of almost 60 to 70%.
Cetuximab also have shown
Yeah,
better
Erbitux,
response.
yeah, cetuximab.
You know,
based
don't
chemotherapy have shown.
get excited with this immuno-oncology. We need more data. It was presented in ASCO. Everybody is telling this. If you look 10 years back, Merrill Keys presented data of cetuximab with 100% complete response in a small cohort when it was new. Let's wait for more robust data to put immuno in neoadjuvant setting. But let me tell you, I advise Merck Sharp and Dome. I'm on the ad board, and they're looking in a big way to bring neoadjuvant into the treatment of head and neck. That's there, because so far it's all palliative and we don't give. So they're looking for a market, and the results are promising, but we need more data.
See, especially in these bulky nodes with small primary coming from hypopharynx or oropharynx, which have a rich lymphatic background, these lymph nodes to chemo respond. I have not published this, but they really respond very well, and which we can see in 3 weeks' time.
Yeah, so
that's all.
yeah.
They do respond, because that is not a classical squamous cell carcinoma.
True.
Am I allowed a question?
Yeah.
Chairperson. What is the NCCN guidelines for NACT these days for?
These are the panelists. I'm just asking the question. I have not answered.
Because even in the first case, and even right now, I think there's a, you know.
Yeah, so first case there was definitely a role of neoadjuvant chemotherapy for a lesion. Yeah, so
CTRT would have been a good option.
I'll tell you, NCCN guidelines for a T1 to T3, N0 to N3, there is a role for a neoadjuvant chemotherapy, induction chemotherapy. For a T4, N0 to N3, again a role of neoadjuvant chemotherapy versus surgery. So both options are there. For a T4A N0 or T4A whatever, there is a role of upfront surgery versus induction chemotherapy. Both are options in hypopharynx. Yeah.
Yes, the primary is not the reason. We are giving neoadjuvant for the bulk of the node. We are not giving for the primary.
Yeah, please.
I'm sticking my neck out here, but bilateral bulky nodal disease, if you're going to do upfront chemoradiation, definitive chemoradiation, how much will be your dose to your critical structures?
I'm going to ask them. I'm going to ask them in the next slide.
Yeah.
I'm going to ask them.
That's too.
I'm not going to comment. They're going to comment. That's the next slide. That's the next slide.
You have a level 1 evidence of giving induction in hypopharynx. So
Absolutely, absolutely. We have.
No, that is the Lee Fabre old paper. That's why it shows as level 1. It was a no one did a CT-RT study after that with pyriform fossa. The only advantage of giving neoadjuvant is it delays or decreases distant metastasis.
Yeah.
Otherwise, there's no benefit. So you must give definitive therapy. This thing that we'll give neoadjuvant, what happens if it doesn't respond?
That is what. We have discussed the same thing.
Patients don't respond.
Absolutely.
With neoadjuvant for both larynx and hypopharynx, we only know one thing, that response, if it is less, these patients do poorly and all of them will recur and
Absolutely.
die.
Absolutely.
It's a biology. That the debate is how many cycles to give. And that's why this concept of Wayne State, Susan Erba and others, they just give one cycle, okay, go for definitive. You give 3 cycles cisplat, then to give CT-RT after that is damn tough. I'm surprised how everybody is saying yes.
So
let me tell you, in the Tremplin study, you all are all quoting Tremplin, 20% of patients could not be randomized out of 68. It did not meet its pre-specified larynx preservation rate of 80%, and they had both pyriform and larynx in that. And there was no improvement survival, and toxicity was the same with cetuximab. So we have to read the fine print of papers and not just say level 1. It's Lee Fabre's paper, bada purana hai paper.
Yes. Dr. Arvind.
No, just one comment on immunotherapy, like neoadjuvant. I think there's some exciting data in nasopharynx cancers, especially with the Chinese neoadjuvant immunos. But I think, as sir said in the ASCO also, it's just sort of just about coming up coming up. In lung, of course, there's a lot of exciting data. In head neck, I think in nasopharynx there are a couple of
lung
studies.
We had a discussion. I think we were there. I was there in your panel. Lung, there is a good data.
I think the message was very clear that in time to come this might come as a modality. Today we don't have evidence.
We don't have nasopharynx. I think there is some little data to suggest that those cancers are little more immunoresponsive. And there are 2 or 3 randomized trials that were come from. Of course, it came from China, so we don't.
So maybe in the next year or maybe OM9 or OM10, we would know some data from one of the medical oncologists. So this patient finally got operated. One meta node 5 centimeter size was positive with external node extension. So what next? When to start adjuvant treatment? Surgeons want to comment. When do we start adjuvant RT after surgery? Neck dissection is done. How much you want to wait? When do we start? Any other surgeon can take.
We can start the neck treatment as of the wound healed by 3 weeks.
3 weeks, yeah. 2 to 3 weeks? Yeah, okay.
3 weeks.
So 2 to 3 weeks we start. So I'll just put all the slides first. Okay. So we go for RT plus CT because the node with perinodal spread was there. We give cisplatin or targeted drug. Cisplatin, okay. What is the dose of RT? Malhar, you can take it. And technique.
Did you cover the carotid artery while doing neck dissection?
I don't know. Time is over. Let us ask about a few more questions. Let's not go into the details of surgery. Expert surgeon has done, Parin has done the surgery. Where is Parin? I don't know, he's not seen. Okay. Yeah.
RT technique will be definitely VMAT plus IGRT guidance, image guidance.
Dose?
And dose to the primary will be 70 gray, dose to the dissected node will be 60 gray.
Okay. So, I agree with what Malhar has said, but the literature says when there is a node with perinodal spread, you can go up to 66 gray to that area. Yeah, so we traditionally don't go up to 66, and specifically what Sir had said, that the carotid will be exposed just below the skin. So we would be very, not very tempted to go for 66 to that area. So routinely we do 60 to that, and in the primary we go up to 69 to 70 gray. Chintan, would you go for a metronomy chemotherapy after, because this was a bad disease?
As of now, we don't have any strong data of this in this.
No, I'm like, I don't believe in any literature. Like, what do you do in your practice? Would you be tempted, like, if this case comes to our MDT, we would discuss in a MDT
so
and decide?
There's no harm because the drugs which we are using is gefitinib, erlotinib or erlotinib. Then there is celecoxib, that is NSAID, and methotrexate. So definitely that can be given, and that is you can give for a prolonged period of time. The only issue is the methotrexate, which can rarely cause, methotrexate toxicity whenever patient may have some renal clearance issues. So we have seen a lot of patients. So if there is good evidence, would be definitely we are using it in unresectable metastatic disease, and along with low dose immunotherapy.
How long do you give it? Like for a adjuvant, like adjuvant CTRT, how long you give it?
There's no data. I'm not using it.
Not using it.
I'm not using it.
Shweta? No. Sir wanted to make a comment?
As of now, we have been treating this patient with a radical treatment,
Okay.
the intent for cure. So what is the point of?
No, there is no point. That is the reason. There is no level 1
not
evidence.
using.
There is
That's why
no-
we are not using.
I'm just asking
As of
as
now,
a,
we are not using
we are
metronome
not
in this
using.
type
Yeah,
of
absolutely. We
radical
are not
treatment.
using. I'm just asking about the experience. Anybody has an experience
not
of this?
using that.
Sir.
I think there is a trial from the Tata's Kumar's group have published, the RMAC trial. If you give metronomic in this setting, I think the results were negative. It was detrimental. So
There
there's
was a
something that you
negative
should
trial.
not give.
Okay. So good comment. Okay, I'll not like.
If I'm not wrong,
I
that
think we should
study
wrap
was-
up now.
Yeah, we'll wrap up. I'll not, just one question. Like it's a T1 pyriform, given radical CTRT, a small T1, T2 primary, of given radical chemoradiation or radiation alone, and the patient failed after 1.5 years. How do you treat this patient? A T1 pyriform treated with radical RT, T1, T2 radical CTRT was given, failed after 1.5 years in the same site. What is the treatment of choice? Anybody want to take it? Just last comments. How do you treat this patient? Recurrent hypopharynx.
If it is again surgically amenable for
T1,
surgery,
T2,
then
T1, T2. The recurrence is T1, T2.
No, at the same site also?
Same site, same right pyriform, same site.
After 1.5 years?
1.5 years.
Status of
No mats, nothing. No nodes, no mats,
fixity, vocal cord.
nothing. T1, T2. Yeah, Malhar.
We can do re-RT.
Okay. Anybody does re-RT? Any radiation oncologist in the audience does re-RT? I don't do it practically. Anybody?
Surgery. I mean,
Yeah.
I would like to say surgery. No, but I would like to ask somebody in the audience who are doing TORS and all this, would they be ready to attempt such kind of thing, or he or she will require something drastic?
This depends on the evaluation of this T1 or T2, whether it is at the apex, whether it is on the medial wall, whether it is on the lateral wall. We have patients where on the lateral wall we have done conservative laryngectomies, voice preserving, and they have done well. So, of course, open. I have never done a salvage endoscopic resections.
The reason of
Like
asking was
Dr.
post-RT. Yeah, sir wants to make a comment.
yeah, I agree with Kostov sir. If the lesion is surgically amenable, the first source will be surgery.
Absolutely. So, so the point here, the point of putting this case here, like we are not going into the detail, was doing a re-RT. We do a lot of re-RT for oral cavity and oropharynx, but doing a re-RT for hypopharynx or larynx is very tough, because the patient is going to end up with chondral necrosis, dysfunctional larynx. So there is like, we have attempted a very few patients of larynx and hypopharynx, and we have burnt our hands. So practically, I don't practice re-RT for hypopharynx or larynx, because the quality of life of these patients will become horrible. It's definitely going to be a dysfunctional larynx. Sir, wanted to make a comment. Exactly. Exactly. So, no. I absolutely agree, sir. Absolutely agree. No. So oral cavity also, like when we do re-RT, it's like an adjuvant re-RT when there is a depth of invasion is more. Radically we don't. Radically it's a surgery only. So whenever there is a debate about a re-RT, it's always surgery. Yeah. So I think I'll stop it here. Thank you so much, all the panelists. Thanks.
Thank you.